All right, so we're going to be going over bleeding and coagulation disorders. Going to include hemophilia A, hemophilia B, von Willebrand disease, factor V Leiden, and protein C and S deficiency. Sometimes these can be a little bit intimidating, and I remember in PA school, I always felt like there was a lot to know with these, but really there's not. And I kind of broke it down to just the basics you need to know, but it's really just understanding the patho, and everything else is pretty simple. Before we start, as always, I wanted to thank you so much for the really nice comments, the new subscriptions. I just really appreciate it, and I'm going to thank you every single time on every video, so hopefully that doesn't get too annoying, but thank you so much again for that. Let's go ahead and get started with bleeding and coagulation disorders, and let's start with the one you'll probably hear the most about, and that's hemophilia A. So hemophilia A is your most common type of hemophilia, much more common than hemophilia B. It's not your most common bleeding disorder, but it's your most common of the hemophilia. So it's an X-linked recessive disorder. This is really important because as far as your vignette, this is 100% going to be a male. It affects the X chromosome, meaning that if a male gets it, males only having one X chromosome, they have the disorder. There's no avoiding it. Females, on the other hand, with two X chromosomes, still have one unaffected chromosome, so they're usually going to be carriers. You do need to know this because it's going to help you in the vignettes. The way that I used to remember this was I used to just remember that hemophilia has the name Phil in it, which is a pretty common male name. And I always used to just think of Dr. Phil. So as soon as I would see hemophilia, I think of Phil and I think of Dr. Phil and I'd be like, oh yeah, this should be in a male patient. And it's little things like this that are going to help you on vignettes. You're going to have a question months from now. You're going to see hemophilia in the answer choices. You're not going to remember a damn thing about hemophilia, but you're going to remember Dr. Phil's bald head and you're going to be like, oh yeah, this can really only be seen in males. Patient in this vignette is a girl. So there's one answer choice I can eliminate. FYI, it's possible for a female to have the disease and have a presentation like a male. It's possible in females with and women with X chromosome loss or deletion. It's way beyond the scope of what you need to know for the boards. They're not going to ask you that. They're not going to give it to you that way. So as far as the boards are concerned, and as far as what you need to know for the exam, this only happens in males. So look for a male when you see hemophilia. Think of Dr. Phil, and remember this is only going to be seen in males. Now, hemophilia A is a deficiency in factor VIII. So the first thing, when you say the number 8, you say the letter A. So when you say 8, you say 8. So you see what I'm saying? That's how I used to remember hemophilia A was a deficiency in factor VIII, because as soon as I'd say hemophilia A, I'd remember, oh yeah, 8. So hopefully you get what I'm saying there. So okay, so it's so as far as the patho, it's straightforward. You have a deficiency in factor VIII. Factor VIII is part of the coagulation cascade, specifically in the intrinsic pathway. And when you have low factor VIII, you have a disruption and decreased ability to form clots. There's nothing really complicated here. Just remember it's factor VIII that you're deficient in hemophilia A. As far as clinical manifestations, patients are going to bleed, GI tract, urinary tract, mucosal membranes, intracranial bleed. But the one that you need to know, the one that's going to be most unique to hemophilia, and that's what you need to start doing on these exams. Focus on what's unique. Don't learn all the things that are going to be the same for all of them. You need to learn what's going to differentiate it. And for hemophilia, that's going to be hemarthrosis, which is bleeding into a joint space. It's the most common site for bleeding in your ambulatory patients with hemophilia, and it represents close to 80% of the hemorrhages you'll see in hemophilia. So as far as clinical manifestations, know this one. How are you going to see it on a vignette? How are they going to present this? It's usually going to be a patient, normally a young boy, minor accident. Maybe they bumped their knee on the playground. Now they have this grossly swollen knee wherever they bumped it. They're going to have swelling out of proportion to the injury. They may also say that the kid has persistently painful joints, always complaining of his knees hurting or ankle, something like that, indicating the hemarthrosis. So look out for that in the vignette. Now moving on to diagnosis, a couple things you need to know here. First thing is your PT, your prothrombin, is going to be normal. Your PTT is going to be prolonged. That's your partial thromboplastin time. So remember, your PT and your PTT are your clotting time. They measure how long it takes to form a clot. So why is your PTT prolonged, but your PT is normal? So let's go over that and kind of explain it. And to understand it, we have to know what PT measures and what PTT measures. So PT measures the extrinsic and common coagulation pathways. So that's going to be factors 1, 2, 5, and 10. And then specifically for the extrinsic part, that's going to be factor 7. So PT measures these factors here, 1, 2, 5, 7, and 10. And then PTT is going to measure the intrinsic and common coagulation pathway. So again, we have the same thing, 1, 2, 5, and 10. They both measure that common coagulation pathway. But the intrinsic part in PTT is what you need to know here. That's going to be factors 8, 9, 11, and 12. What did I say? 8, 9, 11, and 12. That's why your PTT is going to be prolonged, because it's measuring the intrinsic pathway, which includes factor 8, which is going to be what's abnormal in hemophilia A, and then factor 9, which is going to be abnormal in hemophilia B, and that's why you'll also see a prolonged PTT in hemophilia B. So that's why only your PTT is usually going to be prolonged, because PTT measures the intrinsic pathway as well, which includes those factors 8 and 9. So remember, that's why you're going to see that abnormal lab finding. Now, you're also going to do a factor 8 assay that can be decreased or absent because of the deficiency in factor 8. And that's important because in a patient with mild hemophilia, it's actually it's possible that they may have a normal PTT. So you also want to do your factor 8 assay to see if it's decreased or absent. As far as treatment, there's a couple things that you need to know here. First, you can do factor 8 infusions. They're deficient in factor 8, so you give them factor 8. It can be used for prophylaxis. It can be used during an acute bleed. It's really your best treatment for hemophilia A, but it's not usually going to be your first line. So only in hemophilia A do you have another option, and that's with something known as desmopressin, also known as DDAVP. So DDAVP is really going to be your first line in mild cases of hemophilia A. So what does DDAVP do? So DDAVP, or desmopressin, it stimulates release of von Willebrand factor. And why do we want von Willebrand factor? Well, von Willebrand factor is actually partners with factor 8. It binds to and stabilizes, decreases the degradation of factor 8. So when we have more of von Willebrand factor, we have an increased stability of factor 8. So factor 8 stays around longer, which is obviously what we want in this disease. So patients with mild hemophilia A, you have the additional option of DDAVP. Keep in mind, I'll go over this again when we go into hemophilia B, but this is not an option for hemophilia B, because hemophilia B involves factor 9 deficiency. Von Willebrand factor has nothing to do with factor 9. He's only buddies with factor 8. So remember that. DDAVP, only an option in hemophilia A. So what do you need to know for hemophilia A? You need to remember that this is going to be a factor 8 deficiency. Remember, hemophilia A8, factor 8 deficiency. You remember this is going to be a male patient. Remember, Dr. Phil, X-linked recessive. Remember, your PTT is going to be increased because of what it measures. And then remember, you can use factor 8 and also DDAVP specifically. Remember that one because that's unique for treatment. All right, let's move on to hemophilia B. I'm going to run through this one fairly quickly because hemophilia B is almost identical to hemophilia A, outside of two differences that I'll go over, but everything else is pretty much the same, and clinically they present identical. They're identical. So let's go through this real quick. Remember, X-linked recessive disorder. There he is, Dr. Phil. Don't forget that. You're going to see a male in the vignette. This is a deficiency in factor 9, not factor 8. The way that I used to remember that, I just used to remember hemophilia B, factor 9 deficiency, B9, benign, like the tumor is benign. I just used to remember benign, and that used to just help me remember hemophilia B. So maybe that works for you, maybe it doesn't, but B9, the tumor is benign, hemophilia B. Clinical manifestations, this is going to be the same here. Remember, they're going to bleed, but remember that hemarthrosis in 80% of the patients. Diagnosis, identical. PT is going to be normal. PTT is going to be prolonged because remember, it measures the intrinsic pathway, which includes those factors 8, 9, 11, and 12. So that factor 9 is included in PTT. The way that I used to remember which measured what, because sometimes you'll need to know, does PTT measure intrinsic, does PT measure extrinsic, and you can't remember. This is the way that I used to remember it. So PTT, you can see the two T's up top. It's almost like the tops of the T's. They're like holding hands. And that's because T and T are in love. So PTT, they're in love. And that's because PTT measures the intrinsic pathway. And then PT, T's no longer in the picture. He's gone. He's out of the picture. You can see him down there crying. And that's because T and T are broken up. They're X's. And that's because PT measures the extrinsic pathway. So that's just a little trick that I came up with. If you ever forget which is which, and you're like, I can't remember what PT measures, is it extrinsic, intrinsic? Remember, is T still in love, or are they X's? Are they broken up? And that's how you can remember intrinsic and extrinsic pathway. All right, so then also remember in diagnosis, you can check your factor 9 assay to see if it's decreased or absent. And then treatment. So treatment, you're going to give them factor 9 infusions. Can be used for prophylaxis during an acute bleed, just like we did in hemophilia A. But then the key here is you're not going to use DDAVP. Remember, DDAVP only helps out with factor 8, but hemophilia B is a problem with factor 9. So no use of DDAVP, and that's key here. So really the only two differences are going to be in hemophilia A is that this is a factor 9 deficiency rather than factor 8, remember B9, and that you're not going to use DDAVP. Otherwise, they're pretty much the same. So what do you need to know? Factor 9 deficiency, B9, male patient, remember Dr. Phil. PTT is going to be increased, your PT will be normal, and then remember factor 9 for treatment, but no use of DDAVP. All right, let's move on to von Willebrand disease. So von Willebrand disease is a decrease in the quality or the quantity of von Willebrand factor, which is going to lead to bleeding. This is, if you listen to my thrombocytopenia lecture, we went over TTP, which was actually a decrease, or I'm sorry, an increase in von Willebrand factor, which actually caused clotting. Well, this is the opposite. This is von Willebrand disease. We have a decrease in the quality or quantity of von Willebrand factor, and that's why we have bleeding. So less of von Willebrand factor. So what does von Willebrand factor do? Well, Sticky Willie, as I like to call him, his job is to act like glue for platelets. So kind of like sticky paper for flies, but in this case, platelets. So you have an injury to a blood vessel. You have an opening. Body sends Willie out to snatch up, stick to platelets to form a platelet plug to keep that hole you have in the vessel closed up. But in von Willebrand disease, there's not enough of Willie, or Willie's just not doing his job the way he should. And that's the problem in von Willebrand disease. You have this ineffective platelet adhesion due to a problem with Willie, leading to bleeding. So little diagram I made here in Microsoft Paint, so it's terrible, but that gives you the idea. So this is your vessel here. You had a little cut, you had a little opening in the vessel. So what do? These little black sticks here, that's your von Willebrand factor. So the body sends out a call for von Willebrand factor. It's obviously a little bit more complicated than this, but this gives you the idea. And then what von Willebrand factor does is you have all your platelets here. He just sticks to all the platelets. So eventually you have enough of the platelets stuck here and you form a nice platelet plug, which closes up, and that's part of your primary hemostasis to stop the bleed quickly. So that's the idea of von Willebrand factor. And the problem we have in von Willebrand disease is we don't have enough of these, so we have bleeding. Okay, so von Willebrand disease, this is important. It's the most common inherited bleeding disorder. Up to 1% of the population actually has von Willebrand disease, which is crazy. So the most common inherited bleeding disorder. Remember that if they ask you that. Now, there's a few different types. There's actually a lot of different types. There's inherited, there's acquired. Inherited, there's actually, I think, 3 different subtypes. It's crazy to remember all of those. I would never expect you or tell you to do that. The only one I would tell you to remember is going to be type 1, and that's because that's your most common. So type 1 inherited is going to be your most common type of von Willebrand disease, about 75% of patients. So that's the only type I would really commit to memory. Now, clinical manifestations, you're going to have a couple things. You're going to have mucocutaneous bleeding, and you're going to have excessive bleeding. So there's other things that can go on with von Willebrand disease, but those are the only 2 that I would remember. So mucocutaneous bleeding like epistasis, bleeding following dental procedures, and then they're also more susceptible to bruising. So those are the ones that I would focus on for your clinical manifestations. As far as diagnosis, this is going to sound very similar. You're going to have a normal PT, but your PTT is going to be prolonged. Same as hemophilia. So you might be thinking, why is my PTT prolonged? You just told me that PTT measures factors in the intrinsic pathway like factors 8 and 9, but this is a problem with von Willebrand factor, not an intrinsic pathway problem. But actually it is, and that's because what we talked about before when we were going over what DDAVP does, desmopressin. So Willie, his relationship with factor 8, remember von Willebrand factor essentially protects factor 8, like his big brother, helps him to stick around longer. So in von Willebrand disease, there's not as much of Willie, or he's not functioning the way he should, and this leads to increased factor 8 degradation and less factor 8 overall. And what does PTT measure? Factor 8 as well as some other factors, and that's why you're going to see that your PTT could potentially be prolonged in von Willebrand disease, because von Willebrand disease is no longer protecting factor 8. So that's why you're going to see it. Another thing that you may see mentioned, I don't think it's important to really memorize this because it's common sense, but a lot of times they'll mention that the patient started to use aspirin and then their bleeding time was worse, their PTT was even longer. But it's common sense. As I told you before, von Willebrand disease, it's a problem with platelet adhesion. Aspirin's an antiplatelet, so it's going to obviously make the disease worse. That's kind of common sense. Then the other thing you can test for is your von Willebrand factor antigen or your activity, which is going to be decreased or show no platelet aggregation. So There's a number of screening tests for von Willebrand disease. You don't need to know all of them. If they mention a von Willebrand factor antigen test is decreased, obviously she'd be thinking von Willebrand disease. The one thing that I'm going to mention, because it's unique and I think it's kind of interesting, and that's related to the von Willebrand factor activity test. So the way that you measure the activity is with something called ristocetin. So ristocetin, specifically ristocetin cofactor. Ristocetin was actually an antibiotic we used years ago until we found out that it caused platelet agglutination. So we didn't want to use it anymore after that. But when you add ristocetin to plasma in a normal patient with normal von Willebrand factor, it causes the platelets to clump together, and you can visualize that. So if you add ristocetin to plasma of a patient that has von Willebrand disease, you're not going to see this platelet aggregation, and then we know this patient likely has von Willebrand disease. So it's just a way we can use this old antibiotic with this terrible side effect for something specifically in our diagnosis. So I thought that was kind of interesting that I'd mention. As far as treatment, pretty simple here. So DDAVP is going to be your main treatment, especially for your mild patients. So desmopressin, as we went over in hemophilia A, causes the release of endogenous von Willebrand factor. This is going to be the one you're going to use most frequently, and likely this will be the answer on the vignette. So focus on memorizing DDAVP for the treatment of von Willebrand disease. You also have the option of von Willebrand factor concentrates. This is really for patients with type 1 and type 2 disease that have severe von Willebrand disease, or patients with type 3, because type 3, it's a quantity problem with von Willebrand disease, and they have very little, close to no von Willebrand factor. So we can't use DDAVP in patients who have little to no von Willebrand factor, like in type 3 or severe types of 1 and 2. And it makes sense because DDAVP encourages the release of endogenous von Willebrand factor. Well, if you have little to no endogenous von Willebrand factor, it doesn't matter if you take DDAVP, it's not going to do anything. And that's why in severe patients or patients with type 3 who have little von Willebrand factor to begin with, we can't use DDAVP, we have to use von Willebrand factor concentrates. But most patients you'll be able to. So that's what I would commit to memory for treatment. Just remember DDAVP, that's the main one. Now, what do you need to remember for this? Remember, it's a decrease in the quantity or quality of von Willebrand factor. Remember, look for your mucocutaneous bleeding, your easy bruising. Remember, this is the most common inherited bleeding disorder. And then remember treatment with DDAVP. That's the main one I'd remember. And then you also have the option of von Willebrand factor concentrates as another treatment option for those severe patients. All right, let's move on to factor V Lyden. So this is a single point mutation in factor V, which leads to a hypercoagulable state. So factor V is part of the clotting cascade. Helps form clots by amplifying the production of thrombin. Thrombin's an enzyme that converts fibrinogen to fibrin to form our fibrin clots. Anyways, factor V helps us form clots. That's awesome. That's what we want to do. But the problem with factor V is he doesn't really have a stop button. He just keeps going and going. Keeps making more and more clots. So he needs somebody to tell him when to slow down. So the person that does that, or the protein that does that, is a protein that comes from the liver called protein C. So protein C's job is to go to factor V and tell him, all right, you've done enough, slow down, you did a good job, factor V, no more clotting for now. So we don't have clots all over the place. Well, in factor V Lyden, we have this point mutation on factor V. And this point mutation causes factor V to no longer be able to be what's known as cleaved, which is a way of inactivating. That's how that's how protein C inactivates factor V Lyden. So he just does whatever he wants. He doesn't listen to protein C anymore. So think of the point mutation in factor V as like earmuffs. I used to visualize it like this. So the liver's shooting out protein C. Protein C is going to factor V, and he's like, stop, no more clots. But factor V has this point mutation, aka earmuffs, and he's not listening anymore. So that's what happened in factor V. Point mutation, aka earmuffs. Protein C is yelling, stop, no more clots. He can't hear him. He's just going on. And that's why we have this clotting in factor V Lyden. All right, so this is your most common cause of inheritable hypercoagulable state. So that's important to know, because if they ask you a question with clotting, even if you just guess factor V, you'll probably be right because it's your most common cause. The way that I used to remember that, it's kind of silly, but hopefully it works for you. But I used to remember factor V Lyden stood for frequently forming lumps. Those lumps in my head are clots. So I used to remember factor V Lyden was the most common cause of your hypercoagulable state. Frequently forming lumps, that's factor V Lyden. Okay, clinical manifestations. So this is going to be venous thromboembolism, so your DVTs, your PEs. In real life, patients with factor V Leiden, only around 5 to 10% of patients actually go on to develop venous thromboembolism. But in the vignette, they're definitely going to give you that. This patient's going to have a DVT, they're going to have a PE. And then another thing that you may see with patients with factor V Leiden, which I forgot to put under clinical manifestations there, but they may also have miscarriages. So there's a lot of data showing that factor V Leiden can lead to unexplained recurrent late pregnancy loss. It's assumed this is due to thrombosis of the placental vessels, but it's another thing that I remember them mentioning in vignettes. It's this history of multiple spontaneous miscarriages, and then the patient also has a DVT. So look out for that in factor V Leiden. I'm sorry I didn't list it there, but I'm telling you it out loud. So remember, look for miscarriages in factor V Leiden in addition to your venous thromboembolism. Now, diagnosis, genetic testing. So if you have a patient, you suspect factor V Leiden, recurrent venous thromboembolism, family history of recurrent venous thromboembolism, you look for that point mutation as we discussed before, and you do that with genetic testing. And you're going to look for that that problem with the factor V. Now, before you do genetic testing, you usually start with a functional activated protein C resistance test. You do this first. If it's positive, which shows protein C resistance, then you would go ahead and proceed with genetic testing, because obviously genetic testing is much more involved and more expensive. So you normally start, see if there is protein C resistance, and then you move on to genetic testing. As far as treatment, this is pretty straightforward. It's really just going to be anticoagulation. So whether this is just prophylactically prior to surgeries or used indefinitely, it all depends on the risk factor for the patient. So what do you need to know for factor V Leiden? You need to know that this is a mutated factor V out of control, leading to a hypercoagulable state. Remember, this is your most common inherited cause of hypercoagulability. Remember, factor V Leiden stands for frequently forming lumps. Remember, you're going to see your venous thromboembolism as well as your miscarriages. And then remember, you treat this with anticoagulation. Proteincns CNS deficiency, and then we will wrap it up. There's not a lot to know here. This is going to be decreased protein C or protein S, leading to a hypercoagulable state. So I wouldn't dive too deep into the patho here because it become a little bit complicated, but protein C and S, they both come from the liver. They combine with something known as thrombin and thrombomodulin, and they cleave and inactivate factor V, which we just went over. But they also cleave and inactivate factor VIII. More specifically, protein C is involved in this. Protein S is a cofactor. But just to make it super simple, what I used to remember is that protein S and C stand for stop clots. That's what they do. They slow down factors V and VIII, and they slow down clotting. So the problem is, if you have a deficiency in protein C and S, you're going to have more clots. You're going to have a hypercoagulable state because factor V and VIII are no longer being shut down or cleaved. So that's the issue we have here. As far as clinical manifestations, same as factor V Leiden, we're going to have our venous thromboembolism. These patients are going to be more prone to DVTs, PEs. But then we have another thing which isn't only seen in protein CNS deficiency, but it's more common, and that's something known as warfarin-induced skin necrosis. So when you first start on warfarin, it's possible to have this transient hypercoagulable state, which can lead to ischemia, infarct, necrosis because of a clot forming. That's why in our high-risk patients, we actually bridge warfarin for the first few days with heparin or another short-acting anticoagulant to prevent this. But why does this happen in the first place? Well, there's a few different mechanisms. One is just due to how slow the onset is of warfarin. But one of the main causes, and the one that's specific here, is actually from a protein C deficiency. So let's actually explain a little bit about why that happens. So warfarin works by inactivating your vitamin K dependent clotting factors. Basically all of the clotting factors coming from the liver, warfarin shuts or slows them down. So that's factors 2, 7, 9, and 10. But also, what else comes from the liver? Protein C and S. So they're also shut down or decreased in quantity from warfarin. But the problem is they all have different half-lives. Particularly protein C has a really short half-life. So after just a few hours, protein C is already shut down. It's not coming back due to the warfarin. But your other factors, some of your other clotting factors, actually have half-lives of 2 to 5 days. So you have this this balance issue where there's really no longer your body's natural anticoagulants like protein C hanging around, but then you still have a lot of your clotting factors, and that's why you can have this transient prothrombic state due to your natural anticoagulants like protein C disappearing early on. And this can obviously lead to clots, ischemia, infarct, and warfarin-induced skin necrosis due to that protein C deficiency. And that's again why in these high-risk patients we will bridge warfarin with heparin for the first few days to prevent this from happening. Heparin kicks in much quicker and doesn't have this issue. As far as your diagnosis, you can do a protein C and S assay. There's a variety of assay methods that can measure protein C and S activity or levels. Diagnosis of protein C deficiency is basically just establishing and documenting a low protein C or S level. Genetic testing is not often used. It's not really widely available like we saw in factor V Leiden. So treatment, remember, anticoagulation, just like in factor V. Like anyone else who develops a clot, anticoagulation is appropriate for patients with protein C deficiency who do as well, who develop a thromboembolic event. And then you can also treat with protein C concentrate. It's often given prophylactically prior to surgery or in pregnant patients around the time of delivery. So what do you need to know for protein C and S deficiency? You need to remember protein C and S are, you have decreased levels of protein C and S leading to a hypercoagulable state, because remember, protein S and C stop clots. You need to remember your venous thromboembolism, your warfarin-induced skin necrosis, and I explained the patho with the warfarin-induced skin necrosis. I wouldn't necessarily memorize that though. That was just kind of a little bit of extra knowledge for you. I don't think it's important to know for the exam though, for you to memorize. And then remember, your treatment is going to be with anticoagulation and protein C concentrate. All right, let's test your knowledge, see what you remembered here. Question 1. 7-year-old boy presents to the office today with significant swelling over his right knee. Mother states that they were at the playground and he bumped his knee on the slide as he was coming down. She states he's always bruised very easily and often complains of joint pain. Coagulation studies reveal a prolonged PTT, and a plasma factor VIII assay shows decreased levels. What would be the first-line pharmacologic agent to administer in this patient? So that is going to be desmopressin DDAVP. So this patient has a clear presentation of hemophilia A, male gender. You remember this is X-linked recessive. Remember Dr. Phil. Hemarthrosis, which is the most common manifestation in your ambulatory patients with hemophilia. Prolonged PTT, and then of course a decreased factor VIII. So we know this is hemophilia A. And how do we treat mild cases of hemophilia A? That's with desmopressin, aka DDAVP, which increases the release of endogenous von Willebrand factor, because we know that stabilizes factor VIII in the body. Question 2, what is the most common inherited bleeding disorder? That's going to be von Willebrand disease, seen in up to 1% of the population. Question 3, a 39-year-old female presents to the ER with lower leg pain and swelling. Doppler of the lower extremity is performed, which reveals a DVT. She admits this is her third DVT in the last few years. She also has a history of several miscarriages and admits her mother had similar problems with blood clots. Genetic testing in this patient would likely reveal a mutation in which clotting factor? So that's going to be factor V. So first, factor V Leiden is your most common cause of inherited hypercoagulable state. So always be thinking factor V before any of the other ones like protein C or S deficiency. Remember, frequently forming lumps. We know this patient had multiple DVTs. They have a family history of DVTs plus miscarriages. We know these are all potential problems in factor V Leiden. And we know the most likely cause of the problems this patient's having is a mutation in factor V, leading to resistance to it being broken down by protein C. Question 4, hemophilia B is a deficiency in which clotting factor? Remember, that's going to be factor 9. Remember B9, the tumor is B9. And then question 5, a 52-year-old female who was recently started on warfarin for DVT prophylaxis begins to develop necrotic lesions on her legs and feet. A deficiency in which vitamin K-dependent plasma protein likely led to this presentation? So remember, that's going to be protein C. This patient has warfarin-induced skin necrosis. Remember, with the warfarin, the reason we bridge with heparin or low molecular weight heparin in our high-risk patients is due to that transient prothrombic state, due to that protein C kind of getting out of the picture quickly, and then all of your other clotting factors still hanging around for a little bit longer. All right, so that is it. I hope that was helpful. Please let me know in the comments if it's helping you. And then please let me know if there's anything you want me to focus on in the future, which topics you want me to go over, anything like that. So thank you so much for listening to the video. Again, hopefully it was helpful, and good luck on your PANCE, your PANRE, your EORs, and good luck in PA school.